Good morning, everybody. We'll go ahead and start our session on environmental and social determinants of health. I'm Sam Matheny. I'm the Assistant Provost for Global Health Initiatives at the University of Kentucky, and we have a distinguished panel to present to you. I'm going to ask each of the speakers to introduce themselves in turn and describe their background and what led them to the study. And so we will start with John Sandberg at George Washington University.
Good morning, everyone. Thanks for coming on this last day of the session, this rump session. It's good that you came. I think we've got some good papers that are going to be coming up, as you probably saw in the edition of The Lancet. My background, never ask an academic what their background is and why they're interested in their topic. I'll waste my 10 minutes really quickly. I'm a sociologist by training and a demographer. And I'm interested at this point in my career in social networks and how social networks shape cognition and consciousness and behavior, right? And specifically today, I'll be talking about health-seeking behavior in that context. And I'm currently at the George Washington University, if you haven't seen the bulletin. Okay. We have no, do we know how to advance slides on this? Does somebody in the back? Thank you. Makes sense. All right, for a brief outline, the briefest of outlines of what I'm going to talk about today, I'll give you all a brief overview of the ethnomedicine, biomedicine problematic in sub-Saharan Africa. No doubt some of you are familiar with this. This is the area I'm working in. The briefest description of the data I'm using in the study site it comes from. Then I'll spend a lot more time talking about cultural models, right? Which is kind of a new way of looking at culture and a general model of culture and also of cultural and behavioral change. It's not new, but it may be new to public health. And I'll specifically focus on disease causation and therapy in this area. Then I'll give you some results about health-seeking behavior from our qualitative work. And probably at the end, if anybody has some questions, I'll talk about how we're integrating these results into the survey instrument that's currently in the field. All right. So, as many of you probably know, right, there's a duality of health systems in sub-Saharan Africa and other places in the world. On one side, there's biomedicine, which is concerned with naturalistic causation and treatment. And on the other side, there's ethnomedicine, one part of which usually comprises a culturally specific naturalistic component, but also, and predominantly in sub-Saharan Africa, a personalistic or supernatural component. Now, this is often seen as in conflict with biomedicine, right? I've heard public health practitioners bemoan how people waste their money on lotions and potions, right? And how preventable, curable disease and illness gets left untreated because people seek ethnomedical therapy. Now, while this is true, and I can certainly give you some examples in more depth in the current study area, what I want to talk about a little bit is how health-seeking behavior is linked to a broader complex of related cognitive schemas, or a cultural model. Now, for those of you not familiar with the psychological or psychological anthropological literature on this, schemas are cognitive frameworks, right, that we use to provide both models of what exists in the world around us and for behavior in that world, right? These are templates for interpreting stimuli we receive from context and for situated action in that context. Okay, very briefly, this data comes from the Nihar Demographic and Health Surveillance Site. It's an area about 150 kilometers east of Dakar that comprises 35,000 people in 30 contiguous villages who've been monitored continuously for biodemographic and medical events since 1983. On the biomedical side, there are 3 health centers. I've written here really only 2 major ones, right, in the area. And there are regional hospitals both to the north and the south. And of course, major hospital centers in the capital, Dakar, about 4 hours drive away. In contrast to this relatively weak biomedical system, right, there are hundreds of ethnomedical practitioners in the area. We call them guérisseurs in French. Right? Now, though there are some generalists, there's a high degree of specialization among these people. Right? They treat particular symptoms, particular culturally specific illnesses, etc. Now, This data come from a larger project about social networks. It's a survey project, and we collected a lot of qualitative data at the beginning. What I'm going to be focusing on today come from 98 in-depth interviews with a random sample of the adult population of the surveillance zone, consisting of disease narratives. Okay, so here we have a slide demonstrating a cultural model, or a set of cultural models. Now, what are these? These are a set of hierarchically nested cognitive schemas. On the top level there, you see higher level schemas. These are ideas and frameworks for understanding morality, right? Good and evil. And potentially, in the psychological anthropological literature where I draw this from, the main people are Dendrati, Strauss, Quinn, if you're interested in looking it up. Potentially, these provide motivation for behavior. So on the higher level among this ethnic group, the Serer, we see ideas about good and evil tied up with their supernatural cosmology. And as I've discussed elsewhere, I believe this reflects the moral economy in which they find themselves and the necessity of interpersonal responsibility for survival, as well as the dangers of the human and natural environment. Now, these higher level schemas about morality structure, right, mid-level schemas. These are organizing principles, institutions, types of relations that provide the parameters through which action that is implied by the higher level schemas take place. These include things like interpersonal relationships, institutional and non-institutional, obligations, rights, etc., gender systems, ideas about human development and aging, and as well as environmental dangers. Now these in turn, right, these mid-level schemas, structure and are fed up into by lower level or behavioral schemas. Largely lower level schemas are going to be behavioral level schemas. Now these are experiences. These are often thought of as scripts for behavior. In this case you do this, in this case you do that, etc. These include things like, I've written here, exchange relations, sexuality, parenting, etc. Now on the right, I've pulled out mid-level schemas related to health-seeking behavior. On the mid-level, we have ideas about disease, how it's diagnosed, what particular symptoms mean, the context of which symptoms happen, and when the onset of disease happens. And on the lower level, we have behavior, right, in health-seeking. And that is structured by these higher and mid-level schemas down, and then that behavior feeds back up to change. So you can see how this is a general model of cultural change applied to this specific topic. All right, the first thing, and I'm running out of time, I'm sure. The first thing you notice when you read these disease narratives is that almost everybody that you talk to distinguishes strongly between illnesses that can be only biomedically treated, illnesses that can only be ethnomedically treated, and some illnesses for which both types of treatment can be efficacious. There's a very nice quote from a relatively high status man that illustrates this. 5 minutes, that's gonna be tough, but I'll do it. Okay, now despite this really distinct nosological categorization, right, when you look at treatment regimes, people go from ethnomedical to biomedical, automedication back again, these really highly variant streams of treatment, right, that are often serial and sometimes simultaneous. So why the variation in treatment when you've got this very clear, distinct nosological categorization? Well, there are a few things you need to know, and I'll try and rush through them. The first thing, right, with regard to biomedical therapy, very few people understand, right, either the biomedical model or when they seek treatment, what they're diagnosed with, right? Why biomedical therapy is supposed to be efficacious. You ask them, they say, oh, well, they gave me some pills, or they gave me a shot, right? So they don't know. And one of the large reasons is it doesn't fit into this broader cultural model I just described to you previously. There's one really cool exception that has to do with chronic disease and blood. Right? Anemia, hypertension, hypotension, those types of things they accept as biomedical because it ties into a higher level schema about human development and life force that they have already. Okay, ethnomedical therapy in contrast is well supported by the cultural model. On the higher level, they see disease caused by their ancestors, by malevolent agents in the environment. On the mid-level, there are structures of what's perceived as susceptibility by gender in relation to dangers from others. And at the lower level, they're quite familiar with all the treatments they come in contact with, rituals, massage, baths, and ethnobotanicals. Now, this doesn't mean they understand the mechanisms by which these treatments are efficacious, right? But they're more familiar with them on a routinized basis. The second thing that we have to go with here is the social context of diagnosis and treatment. right? These higher and mid-level schemas, I would maintain, shape who's perceived as susceptible to illness, what counts as illness, right, and what treatment options are. Now, these schemas about these things are distributed, right? There's a lot of variation around them in the population, and how this comes into play through social networks, right, is that as someone presents as ill in a residential compound, diagnosis moves from close kin and co-residents to an ever wider network of kin and neighbors. Somebody will come over and say, oh, I heard your kid was sick. What has he got, that thing with his eye? Yeah, my brother had that thing with his kid, had that thing with his eye. You need to go to this person because it's X, right? And everybody comes in and feeds in their opinion about what's going on. So there's a strong social learning effect from previous experiences. There are other network effects that I could talk about here, but for want of time, I will skip over. The last thing, or the third thing I want to talk about today is perceived efficacy, right? Now, perceived efficacy also works through social learning and feedback mechanisms, right? Reinforcing or undermining particular cognitive schemas in this cultural model. What's interesting is you'd think biomedicine would have the advantage with regard to efficacy. It doesn't, right? When you read these narratives, some people will say they were well treated biomedically, some people say that it won't cure them, and it goes the same way with ethnomedicine. So why is this? Well, biomedicine in this area has an advantage from the historic elimination of measles and meningitis through vaccine programs, through reductions in infant and child mortality, through a legacy of itinerant physicians who work for the project that collects this data, and also through the efficacy of appropriate treatments in some specific cases, say childhood diarrhea, or what the people there concerned or consider simple malaria. Ethnomedicine's advantage, on the other hand, are the limited resources, first and foremost, the limited resources of health centers, right? There are some illnesses that biomedical centers cannot diagnose and or treat. And I've given you a couple of examples. We can talk in some depth later if you're interested. Now, what I find interesting here is that when biomedical intervention is ineffective or not available, this is interpreted as a failure of the biomedical model. Right? And people turn, in that case, first to traditional schemas of causation and treatment on the ethnomedical side. When ethnomedical intervention is ineffective, on the other hand, that's not necessarily interpreted as a failure of the ethnomedical model. Why? Well, there are three key reasons, I think. First is the plurality of ethnomedical causes. Certain symptoms can have a variety of causes across the panoply of illnesses that they assign culturally. Secondly, the plurality of ethnomedical practitioners that I mentioned at the outset here means that if you go to one practitioner and they give you one ethnobotanical treatment or they give you a massage, that does not necessarily vitiate the diagnosis you have, right? That just means you chose the wrong practitioner and the wrong therapy. And that may be so to a certain extent under the biomedical model, but not with the resources that the health system here has to contribute to the area. So in closing, I don't like to make programmatic suggestions, but I think to gain against ethnomedicine, right, curative biomedicine has to be more efficacious instrumentally on the ground to feed back through that experiential loop from lower level schemas. Preventative medicine is fantastic. It saved thousands of lives in the area, but it's not easily perceived as efficacious, okay? And finally, to integrate biomedical therapy into cultural models may provide another way, right, to move the dial a little bit toward the biomedical side. And that might be done through analogies in the cultural models that we're talking about to the particular symptomology and treatment from the biomedical side. Sorry, I went way over. Thank you.
Next, we have Amita Do Denny, who will be discussing caregiver-infant interactions in the context of prenatal environmental health exposures in rural Costa Rica. Dr. Dudani is from York University in Canada.
Hi, everyone. Thank you all for coming here, and thanks to CUGH for having me. So I'm a PhD student in the Clinical Developmental Psychology program at York University in Toronto, Canada. And this study that I'm going to talk about was my dissertation research, which looked at caregiver-infant interactions in the context of environmental exposures, or specifically pesticide exposures in rural Costa Rica. So just to give you a little bit of background first, pesticide use in Costa Rica is among the highest in the world, and it's the highest in Central South America. banana plantations continuously apply high doses of neurotoxic pesticides. Some of them are known endocrine disruptors, and as you can see here in the picture, sorry, I don't know where to point the pointer here. But anyways, you can see in the picture that aerial spraying of one of the known neurotoxins and endocrine disruptors called mancozeb is very frequent and happens on a daily basis. Pesticide exposure exerts its effects on health and neurodevelopment via multiple pathways. And prenatal exposure to pesticides has been associated in a number of studies with developmental problems in multiple domains, as you can see here. And this is in childhood and even as children get older. So why look at quality of caregiving, which was the focus of my research? Well, it's been recognized by the World Health Organization as one of the most significant modifiable contributors to children's development, and this is across cultures and in developing and developed countries. And we know that positive caregiver-infant interactions, particularly in the early years of childhood, significantly are important in fostering secure attachments between caregivers and their children. And in the context of poverty, we know, and other negative environmental conditions, we know that this factor has been shown to help buffer children or increase the resiliency of children against the negative effects. So this factor has not been looked at to date in the context of environmental exposures. There are two groups of studies that consider children who've experienced prenatal adversity. Well, first group of studies is from children who've experienced prenatal drug or alcohol exposure. So studies in that domain have shown links between caregiving and improved positive caregiving and improved developmental outcomes of children. The second group of studies are epigenetic studies, which have shown that young rats who've experienced prenatal adversity and when they're cross-fostered and raised in high nurturing environments, which is represented by high licking and grooming towards young rats, they show higher gene expression and then which translates into better behavioral regulation in these rats. So this brings me to the objectives of my study, which were first of all to explore and describe this, the quality of caregiver-infant interactions in this high-risk sample of infants who've sustained prenatal pesticide exposure. And secondly, to examine the associations between the quality of caregiver-infant interactions and one-year infant neurodevelopmental outcomes. And this was a pretty exploratory study because given the dearth of research in this area. So for today's talk, I'm just focusing on the second objective. This study was part of a larger study, which is a prospective cohort study that is looking at the effects of prenatal exposure to pesticides on infant neurodevelopment. And this study is called the Infantes y Salud Ambiental. And what I did is I did home visits with 94 caregiver infant dyads, which were a random sample from the overall study sample of 451 dyads that are living within one of 40 villages spread throughout the county of Matheny in the province of Limon. So just to give you a visual, you can see on the left that's the map of Costa Rica. Limon is the province that's along the Caribbean Sea. And the one on the map on the right is a map of Limon, and you can see that Matheny is the county that's sort of in the middle of the province. Limon is known as one of the poorest regions in Costa Rica, and the majority of banana production takes place in this province. So caregiver-infant interaction quality was assessed using a measure called the Nursing Child Assessment Satellite Training, or the Endcast, and we use specifically the teaching scale of this measure. Basically, parents are given a list of activities and are asked to choose the activity from the list, the first activity from the list that they've never seen their child do. And then they're given the materials for this task or this activity and asked to try and teach it to the child. It's not important whether the child succeeds or not. That is emphasized to the caregivers. They're told that they just are going to try and teach this activity to their child. So these interactions were videotaped and independently coded by myself and another trained research assistant. So this is the subscales within the Endcast. The Endcast has 73 items that are rated on a yes, no, whether you observed the behavior or you didn't, and it's based on the bidirectional transactional framework of child development. So basically that asserts that the caregiver's contribution as well as the infant's contribution are both equally important in the development of children and in caregiving in particular. So, but of course in early infancy, the caregiver has the majority of the responsibility to direct the interactions. So 4 of the subscales are from the caregiver's perspective and 2 of them are from the infant's perspective. It gives you a caregiver total, gives you an infant total as well, and then you get an overall interaction score, which represents the quality of the interactions. 1-year infant neurodevelopmental outcomes were assessed using the Bailey-3, which assesses developmental outcomes in 4 broad domains: cognitive, language, motor, and social emotional. And then there's 4 subdomains, so there's 2 subdomains of motor development and 2 from language. So I'm just going to go through the results. First of all, in terms of the characteristics of the sample, so these are the child characteristics. Children were on average 21 months of age at the time that the Endcast was applied and caregiver-infant interaction was measured. They were around 13 months of age at the time the Bailey was administered, and 60% of the children were males. And I should mention that these characteristics that I'm presenting are representative of the overall study population of this longitudinal study. In terms of maternal and caregiver characteristics, so this caregiving measure was applied with the primary caregivers of the children. In the majority of the cases, these were the biological mothers, but the others included fathers, grandparents, and extended family. So the average age at the time of the Endcast was around 28 years. Moms had a mean level of education of 7 years, and this was similar for dads as well. I'm only presenting some of the characteristics, not all of them. 71% were married. Maternal intelligence is estimated by the WASI full-scale IQ was in the below average range. And overall, the mothers were not reporting any significant levels of depression. In terms of social environmental characteristics, you can see that the median residential distance to banana plantations was pretty low. So many of the villages, so it's around 267 meters, many of the villages are quite immersed and very near to the plantations, contributing to higher levels of exposure. And the median family income was only $120 US per month. So this is a low SES sample in these communities. This is a table of showing you the 1-year neurodevelopmental outcomes of the infants. All of the scores are age-standardized scores that were adjusted for prematurity. So you can see that overall they were within the average range across all the domains. I guess the lowest score relative to the others is on the receptive communication subtest of the language scale. However, that's still within the average range. So what we did is when we looked at the association at the bivariate level between caregiver-infant interaction quality and neurodevelopmental outcomes, we found that it was significant for 2 domains of development, language and specifically expressive communication. So we did hierarchical regressions. We wanted to see how much does the quality of interactions contribute to developmental outcomes above and beyond the control variables, which we entered in block 1, child sex, caregiver age, and maternal education, and exposure. And in this case, in this study, we used the residential distance to plantations as a proxy for exposure. We found that the only significant association was for expressive communication. It remained significant. It's a small proportion of the variance. However, it did remain significant after adjusting for these other variables and exposure as well. So it accounted for 7.2% of the variance in the expressive language skills of these infants. So this was just a snapshot of the study, but I guess one of the main strengths of the study is that it is the first known study to date to look at this factor, caregiver-infant interaction quality, in the context of environmental exposures. And there has been growing evidence in the environmental health field of the importance of social and parenting factors, or the home environment, in predicting developmental outcomes of children. Some researchers purport that this factor accounts for greater proportion of the variance in exposure itself. So I guess it's some early evidence, and again, this was an exploratory study, so really, it needs replication and further study, but it does point to this environmentally modifiable factor, such as caregiving, which may need to be further considered in the context of environmental exposures. And also, it's the first study to utilize this measure, the Endcast, which is a well-utilized measure in research. However, it hasn't been used in developing countries to date, or in a Spanish-speaking population outside the US. Every study has limitations. Some of the limitations of our study is that the Endcast, while it is a very useful and well-researched, well-validated measure, some of the aspects that are measured by the Endcast may not be culturally relevant to this population. And caregiving in this sample is very highly linked to other social determinants of health, which are very linked to the poor living conditions in the sample. Of course, this was also a cross-sectional study, so there's limitations with respect to that. So just to conclude, what we found in this high-risk sample of infants with prenatal pesticide exposure is that caregiver-infant interaction quality was associated with language and remained significant for expressive language ability after adjusting for exposure. So caregiving might be a factor worth exploring in this context. The associations may become stronger over time as these children grow up, and it may play a mediating role in the development of children. So while it's important to while it's crucial to work on pesticide reduction and risk reduction strategies in these environments, we think that it is important to also start considering other factors such as caregiving, which are more easily modifiable and amenable to help improve developmental outcomes of children. I'd like to thank these people for the study, and most importantly, it wouldn't be possible without all the families that participated in this research. And thank you very much. Sorry, I probably went.
Thank you, Ameeta. Our next presenter will be Stephanie Koenig from the University of Wisconsin in Madison, and she is going to be discussing universal health care coverage and its question about restriction for access on receipt of obstetric care in northern Thailand.
Good morning. My name is Stephanie Koenig, and I am currently completing my PhD in population health and sociology with an emphasis in demography at University of Wisconsin-Madison. Today, I am discussing a working paper that investigates how Thailand's universal healthcare coverage plan was rolled out in northern Thailand and how it affected public healthcare use for different ethnic minority populations living on the Thailand-Burma border. This talk and paper comes out of a larger study I began with UNESCO in 2010, in which I combined survey and interview data to investigate what factors were driving Highland or quote-unquote hill tribe women's healthcare seeking behavior as Thai public health services became increasingly available in northern Thailand. Thailand's universal healthcare coverage plan introduced in 2001 was one of the key factors that I examined in this study, and I highlighted it today as a relevant case study for evaluating the effectiveness and scope of national universal coverage plans. I investigate whether Thailand's installment of the plan actually reduced barriers related to receiving care for underserved populations in the country. In order to do this, I focus on Thailand's diverse population living near the Myanmar border region, where health and mortality risks are disproportionately high, and healthcare access and use has been historically low. Thailand faces many challenges related to serving an ethnically and linguistically diverse population that covers a relatively wide range of climates and topographies, experiences the dual burden of communicable and non-communicable diseases, and includes both a large indigenous and migrant population, even within single ethnic and cultural groups. I'm talking about a minority population numbering in the millions. These circumstances, along with Thailand's well-developed public healthcare policies and provisions, present valuable opportunities to evaluate the effectiveness of public health approaches in improving health generally and removing health disparities, which could be adapted to a wide range of countries, including high, middle, and low-income countries. Thailand's universal plan was widely recognized as a revolutionary approach to providing comprehensive and affordable national health care. It focused on reducing healthcare-related costs and reducing any cost-related barriers to seeking and using care, which it was probably at least somewhat effective in. However, there were additional unintended consequences of the plan, which I discovered in more qualitative research I conducted in 2009 and 10. The plan entailed the installment of a new health branch that administered the population's healthcare budget, determined on a per capita basis and allocated based on household registration. When I interviewed different healthcare administrators and providers in the rural north, all of them expressed frustration with this new approach, at least to some degree. They insisted that they were already essentially providing universal care. Healthcare was already affordable, and clinics were budgeted to cover exceptional cases where patients were unable to pay. The new plan, however, required that clinics police who was and was not eligible for care in order to collect proof of residence and registration from patients in order to receive adequate reimbursements from the government. Thus, a policy was designed and then praised for reducing barriers to care, appeared to actually have created a whole new set of barriers to care by creating a new infrastructure based on funding that bound care providers to a rigid reimbursement protocol for a set list of registered patients. You can imagine how this presented barriers for individuals that didn't speak Thai as their first language, didn't have appropriate documentation of registration, and had other difficulties communicating with care providers or were seeking care outside of their catchment area. These unintended consequences further warrant a closer look at the effects of the plan on care use and related inequalities. I focus on healthcare received during pregnancy and childbirth. Although Thailand's reported maternal and infant mortality rates are relatively low, these deaths are known to be drastically underreported and disproportionately high in rural parts of Thailand and among ethnic minority groups. I look at use of hospitals or clinics for childbirth as a common form of healthcare that this policy potentially influenced, particularly for underserved populations. Clinic-based care for childbirth, while not always necessary for ensuring that a childbirth is safe, serves as a useful indication or proxy for the relative probability that a childbirth has occurred under low-risk conditions as compared to home births. Additionally, all women that I interviewed, representing a wide range of cohorts and ethnic and cultural groups, stated that they would prefer to give birth in the hospital. Now, I'll briefly present a summary of the general trends we see in women's changing use of clinic-based childbirths and my estimation of the impact of the universal plan in this process and how it modified barriers to care. I use UNESCO's Highland People Survey, which I was involved in the design and collection of, which surveyed all registered villages in the Myanmar border region as depicted in this map in 2010. As illustrated in this slide, the proportion of clinic-based childbirths has increased dramatically over relatively recent history. This has likely occurred due to a combination of changing social and physical environments, including the construction of more local health clinics that became widely available by the late 90s. In order to assess how the plan influenced use of hospitals for birth, I modeled pre- and post-policy levels and trends in use in order to infer what changes in use were likely attributable to the policy change. Here I have plotted the change in the log of the probability of giving birth in the hospital over time within villages. This graph illustrates women's propensity to give birth in the hospital by village increasing over time, and the universal coverage plan creating about a 30% increase in the proportion of women giving birth in a hospital in a given village. Now, this analysis provides a clear representation of the average change in hospital births that were related to the policy change among the general population living near the border. However, it is masking important effects on individuals that vary significantly by sociodemographic characteristics. To look more closely at this, I model individual women's propensities to give birth in the hospital, conditioned on year and important factors related to using care before and after the policy. This is a plot of the relative odds of a woman giving birth at the hospital. We see that before the plan, and this is among women that gave birth within 10 years before the plan. We see that before the plan was installed, a mother's language, education, citizenship, and wealth significantly influenced different access and use of care. And after the plan, we see that these barriers or barriers related to these factors are persistent and potentially even more severe, particularly for women with lower educational attainment. So do we see signs of reducing barriers to receiving care for these underserved populations? I would argue yes, but. We do see a general increase in hospital use for childbirth, but inequalities persist by language, education, ethnic minority status, and citizenship status. Interviews and ethnographic research additionally suggest that these barriers have become larger for the most underserved groups, including ethnic minorities that do not speak Thai or do not have citizenship in their country of long-term residence. Those among the greatest in need, I would argue. That is all, but I actually glossed over a lot of even the strengths and limitations of this study for the sake of time, but I encourage you to ask any questions or provide any feedback you'd like during the discussion. I'd like to thank colleagues at UNESCO and also at University of Wisconsin-Madison, as well as the agencies and institutes that have helped fund this research. Thank you.
We'll now hear from Lisa Thompson at the University of California, San Francisco, who will be discussing air pollution and then cooking fires and its relationship to infant neurodevelopment.
It's still good morning. We're almost at good afternoon. I am an assistant professor at the University of California at San Francisco, and I'm going to be talking to you today about my research in Guatemala. This study is called NACER, which means to be born in Spanish. And it's a study that looked at the relationship between exposures to household air pollution during pregnancy and the impact on infant outcomes. And the study just finished in January 2014. I'll be showing you preliminary results of our pilot study. Why household air pollution? Maybe some of you heard the early speakers who talked about this problem in the global context. But 40% of the world, or 3 billion people, are exposed to household air pollution. It is responsible or associated with 4 million deaths annually. And it's one of the top 5 risk factors for ill health. And for neonates, it's not yet completely quantified because the burden isn't known. There are not enough studies to really get at the estimate. But in the recent Lancet article in 2012, it was estimated to be one of the top 2 risk factors for neonatal death, second only to suboptimal breastfeeding. The specific aims of the NACER study, since it was a pilot study, was to measure personal exposures to household air pollution, specifically looking at carbon monoxide, particulate matter, and polycyclic aromatic hydrocarbons during pregnancy and the first year of infant life. And the second measure aim was to collect standardized measures of birth weight, length and head circumference, newborn gestational age, and neurodevelopment. And we did this through the first year of life, and this was basically to develop the methods for a larger study. These things may seem simple, but they're actually not that simple. And getting at measures, personal measures during pregnancy is very challenging. We enrolled 36 women during pregnancy, and since women don't go to prenatal clinics early in their care, our inclusion criteria was that they be less than 20 weeks gestation, and we did this confirmed by ultrasound. We measured health at baseline and at monthly home visits. We measured maternal personal exposures to air pollution at less than 20 weeks, 24 to 28 weeks, and 32 to 36 weeks of pregnancy. So we don't have first trimester estimates. When children were born, we had to develop a method to arrive at the house where most of the children were born and assess their birth weight, length, head circumference, and infant neurodevelopment. We assess these at 48 hours of birth, within 48 hours of birth, 1 month, 3, 6, 9, and 12 months. We also were able to measure maternal urinary metabolites of exposure to wood smoke, specifically polycyclic aromatic hydrocarbons and volatile organic compounds. So a little bit about the participant characteristics. This is a universally poor region of Guatemala, one of the poorest. We had 44% of our women were between 17 and 22 years of age, so very young. 78% had completed elementary school. 78% were indigenous Mayan, mom-speaking women. They were farmers, had large household sizes, and pretty much came from the same household structural materials, which is important when you're measuring air pollution, and that they had a laminated metal roof, cement walls, cement floor. They did have electric lighting, and they lived in a one-room structure. Also important when you're trying to get at the estimate of household air pollution is other combustion sources besides the cook stove. So these women burned garbage outside their homes, mostly to cook animal food. They also, in this part of the world, use a wood-fired sauna bath, which they use for bathing once or twice a week. We did have 6% of the households that reported that there was a smoker in the home, and this was about 1 or 2 cigarettes a day, so that's negligible in terms of exposure. For infant outcomes, we had 31 infants that were delivered, and we had 27% low birth weight, which is twice the national estimate. We had 8% preterm among the live births. We did have 3 preterm infants that died before they weren't delivered live. But our preterm was only, the lowest limit was 34.4 weeks, so we're not talking about very, very early preterm. Stove stacking is the concept among environmental scientists that looks at the fact that people don't just have one stove, they have many stoves that they use. And in this study, we had 33 homes that had the kitchen in a separate structure and 3 that actually cooked inside the area where they slept. And all of the chimney stoves were deteriorated. In fact, 2 had no chimneys at all. That was their primary stove. Secondary stove, we had 3 open fires that were inside the homes, and 6 LPG gas stoves, which is quite important for looking at household air pollution in the future and moving towards a clean fuel like LPG gas. I also wanted to highlight that 47% of the households reported burning plastic, which is a significant problem for other terrible exposures to things like dioxins and other carcinogens. How did we monitor air pollution? And this was a bit tricky. We measured personal exposures. We had to construct these harnesses that women wore for 48 hours during the 3 trimesters. And then during infancy, they either wore the harness or they kept the harness by the baby in the bed, as you can see in the lower picture. We measured carbon monoxide and particulate matter using both filters and continuous monitors, which measured every minute, and they also wore little polycyclic aromatic hydrocarbon filters. What were the results? Over 9 monitoring periods, you can see that for particulate matter, the 48-hour mean was higher during pregnancy than it was during the neonatal and infancy periods. These are 2 to 5 times higher than the WHO air quality guidelines, so they are high. For carbon monoxide, the 48-hour means were a little low, but these estates, there have been studies of single pollutant models where they found that 1 ppm or parts per million of carbon monoxide actually did affect fetal weight during the 3rd trimester. But the peak exposures are the ones that are very high, and these are peak personal exposures. This is not the kitchen. This is what the woman is breathing in because she was wearing the monitors or the infant. These box plots are the urinary polycyclic aromatic hydrocarbons, and what we did is we had the women measure over a 72-hour period. They gave us a urine sample, fasting in the morning, after lunch, after dinner, and after the sauna bath. And there are eight different metabolites of polycyclic aromatic hydrocarbons, and what really stands out on this graph is the high exposure during the sauna bath. And using the same lab methods, the Benowitz lab at UCSF did the same testing with 187 people that smoked more than 20 cigarettes per day. And their geometric mean exposures are illustrated here. So all the levels were above an active tobacco smoker who smokes more than 20 cigarettes a day. So another important aspect of the test, and something that we piloted, was the use of a rapid neurodevelopmental assessment tool, which is an instrument developed in Bangladesh for use with semi-skilled health workers. This was validated. We validated this against the Bailey scale for infant development, which was shown in one of the presentations. That's the gold standard, but it's something that's difficult for people like traditional birth attendants or community health workers to administer. So we trained them on the use of it. It measures 9 domains, and I'll show you the results on the other slide. But basically, the findings from this study were that we found mild impairment in about 10 to 20% of the infants that we assessed. And these are the 7 domains that I'll show. The other 2 I didn't put up because we looked at seizures and there were 0 report of seizures, and then we looked at primitive reflexes in the neonate. But across the age groups, these are the children, and you can see the different percents for moderate to severe disability that ranged between 5 and 15%. But looking at the 12-month period, between 0 and 10% showed some moderate to severe disability. So, for instance, gross motor is at 12 months. Can you pull to stand and cruise around on chairs? Can you hold a cube in your hand for fine motor? And then the importance of this tool is it also assesses vision and hearing, which the Bailey scale of infant development doesn't do directly. Another thing that we looked at was the stunting. So the children in this area are chronically malnourished, and there's a lot of stunting. So we looked at the height for age Z-score using the WHO reference standards, and we tried to see if we could see a difference in terms of neurodevelopmental impairment based on the height for age Z-score. And these are all the ages lumped together into one group. And you can see that for gross motor, speech, and cognition, there was a statistically significant difference between those that had moderate to severe stunting versus those that didn't. The next steps, really, since the study ended in January, is to look at the air pollution measures, qualifying that with the fact that we only have 31 people in our study, but we did follow them for 20 months of time and have 9 measures. So we'll be able to at least say something more definitively about the air pollution exposures, which was our primary interest. So conclusion, the assessment of the neurodevelopmental impairment using this RNDA 27-item, very simple instrument is easy to perform with trained community health workers. This instrument was developed in Bangladesh, so the things that are used in low-income settings relate to infants in these settings. and maybe more culturally relevant than looking at something like the Bailey Scale of Infant Development. But it is a new tool, and it still requires validation in different settings. The second point is that personal exposures to particulate matter exceeded levels that were needed to protect maternal and infant health. We found maternal urinary metabolites of wood smoke exceeding levels seen by heavy active tobacco smokers. We're currently enrolling a cohort of 200 pregnant women in Guatemala using same methods as developed in this pilot study. And we're conducting stove testing to determine the optimal stove for future dissemination work in areas where people are highly exposed to household air pollution. Thank you.
Our last presenter will be Eric Ting, Harvard School of Public Health, and Eric will be talking about the relationship between long-term body weight and glucose management effects in Jordan. Eric.
Thank you very much. I know I'm standing in the way for everyone's lunch, so I will try to maximize my 40-some slides in minimal amount of time. So, the main presentation is the top one on long-term body weight and glucose effects of our microclinic social network intervention program in Jordan, as well as a part 2 preview of the program in a randomized trial, in a 3-arm randomized trial that we were doing. And the second one was the one that won the CUGH Global Health Project of the Year award yesterday. So I just want to give everyone a preview of that results. Should I just click the mouse? Okay. So the funding, Microclinic International is a 501c3 nonprofit. It was supported by IDF and the Mulago Foundation, and I have no conflicts. I'm supported by AHA and ADA. So the potential social networks. A quick adage is if you want to go fast, go alone. If you want to go far, go together. Hence the power of communities and villages in having greater long-term effects. Social networks in health, very briefly, social networks interactions play a very meaningful role in disease prevention, from smoking to obesity to alcohol use. Factors are correlated, have been shown in social networks, such as Christakis' studies with the Framingham Heart studies on the propagation of social networks over many years in the Framingham cohort. Thus, if behaviors may naturally aggregate in social networks, then interventions that leverage social networks therefore may hold promise to induce and propagate positive health behaviors. What's going on? So, for example, this is the Christakis studies in New England Journal, the spread of obesity in large social networks in 32 years. In addition, his smoking, if you smoke, you're more likely your friends will also smoke. If your friends quit, you're also more likely to quit. And same for alcohol in the Annals study, if this thing clicks. Again, social networks, there's social networks of 2, social networks of larger individuals, and these individuals are also nested in other social networks in which they have interrelationships with others. Okay, so social networks, there's 3 types of social networks in general. And this is what Nicholas Christakis did not separate. There's induction, which is causation. A friend nags the other friend to go to the gym, and the friendship leads to the weight loss. There's homophily, which is selection of reverse causation, sort of combined into one. It's the birds of the same feather fly together. Jane and Jen form a new friendship because they both are skinny and gravitate towards each other as friends, such as what happens oftentimes in sorority clubs on college campuses. It's not that because their skinniness caused other to be skinny, they inherently self-aggregated because they're skinny and pretty. So the body weight inherently affected and led to their friendship. That's reverse cause. And then there's confounding, it's non-causal correlation, as we all know what confounding is. And the limitations of this is you cannot prove direct causation with the Christakis study, and you cannot disentangle the 3 types of social networks inherently, and it cannot answer interventions in public health can be propagated to induce and spread healthy lifestyles necessarily. So the Microclinic International philosophy is that if chronic disease can be biologically infectious or non-infectious, and epidemics are often driven by behaviors that spread through their social networks. Therefore, if unhealthy behaviors are socially contagious, then bad behaviors can spread, and so can good behaviors for positive health. So social networks plus unhealthy behaviors leads to poor health outcomes. However, social networks plus healthy behavior can lead to positive health outcomes. And so this is basically, it's a very lay oversimplification of how social networks can propagate these positive health behaviors. And an inherent microclinic social network model is structured in which there's an intervention, there's a clinical program with more than one individual, but it's actually groups of individuals in a classroom. And the goal is that these scale up on themselves in terms of the social network effect propagating to the rest of their families and the rest of the community. So the microclinic program, microclinics are groups of individuals and family and friends who form together into microclinic units for participation together in the health program. And multiple microclinic units are nested within classes, so it's actually several friends and family clusters within a class, within neighborhood community clusters, et cetera. And again, the program, its goal is to strengthen social interaction, foster friends and family within a microclinic units to share personal health information, and encourage sharing and propagation of the health behaviors between them. So the problem in Jordan, again, the project is in Jordan. We have many other projects, but for the Jordan, 1 in 5 people have diabetes, 40% are undiagnosed, half of them are obese, and the number is climbing, and the incidence is expected to triple by 2030. And total direct cost is over 600 million JDs, which is approximately 1 billion. Oh, I think we skipped over. So study setting it's in the capital of Amman, but Amman, there's many different neighborhoods as well. Diabetes prevalence is very high, needless to say. So hierarchical structures. So within each cohort study wave, we have different neighborhoods. We have Al-Nasser, and basically many communities within Amman. There's different classes, 1 class per week, and then there's multiple microclinic clusters within each class, and then multiple individuals within each microclinic friends and family cluster. All right, the program was conducted in collaboration with Queen Rania's Royal Health Awareness Society and Jordanian Ministry of Health, who both donated some resources and also support. Weekly classes led by nurses training diabetes education and health, plus our unique social network-based microclinic program. So it was a diabetes plus education program. The intervention itself was 4 months, and we have 1 and 2 year follow-up in this old long-term study. So the characteristics, about 300 people, women about 2/3. It's relatively middle-aged, and there were relatively high BMI. Average BMI was 32, and A1C was pretty high too. So just a few pictures. This is Queen Rania visiting our clinics. All this was obviously done in Arabic, and we have a great team there at Microclinic International. So just skipping to the quick results, weight and BMI, 4 months, 1 year, 2 year. And if you follow the mean weight and BMI, or I just showed them together, obviously they go hand in hand. After 4 months, you have negative 2.8 kilogram loss. 1 year follow-up, they kept 1.8 kilograms. In 2 year follow-up, they still had negative 1.6 kilograms. And BMI was similar. And for HbA1c, this is a diabetes program, so obviously we measured A1C. We had half a unit A1C drop, which is quite significant if you know A1C units. But notably, at 1 year and 2 years, the results were sustained, and at 2 years, they were actually even somewhat higher. So again, A1C is a long-term metric, and so those previous weight loss that you previously observed in the previous months and years probably sustained itself and led to the long-term A1C metric decreasing. So success in Jordan, again, 82% of the people completed the program, and 2 years later, weight loss and blood sugar remained low. So it was pretty effective for obesity glycemic control in the relatively resource-limited setting, and an inexpensive 4-month program had lasting effects of 2 years. But of course, control group comparison. We need a control group comparison because to adjust for temporal trends, so we need a trial. So this is the second part of this. We'll do a very short preview of this. Again, leveraging pre-existing social networks to propagate health, we conducted the first ever social network randomized trial to improve obesity and diabetes in a developing country. A 3-arm trial of 7 to 8 months intervention, followed by 9 months follow-up and 9 months and 16 months. But we're just showing the quick early intervention. It's a multi-level trial. So it's a 3-arm trial. The trials arms are basically group A, B, and C. A is education with microclinic, or social support. But the other group B is education alone without the social support, and the C is just pure standard of care, no support, no education, but they're still being measured and screened. So we're trying to remove the screening bias as well as the education bias. Well, not bias, confounding. So baseline measures, we have about 500 individuals in the group A and 185, 187 B and C. The inherent difference is that we structured it like this. We wanted more people in the social network groups because we wanted the social network groups effects to be more measured. So hence we randomize in unequal ratios. So the quick result is basically, remember at the beginning I said, if you want to go fast, go alone, but if you want to go far, go together. And we have basically have this exact quote in the African proverb being reflected here. It's a tortoise and hare story. At 12 weeks, which is mid-intervention of the program, education alone reduced weight versus control of 1 kilogram, while education plus social networks yielded up about 60% of that drop. However, at the end of the full 28-week program, social network education came out ahead and sustained weight reduction of negative 1.1 kilograms versus control, while education alone receded in effect, basically rebounded, as you see in most weight loss trials, that it's not sustainable. And hence, it's the social network effect that's sustaining the effects long term. And the overall P for time by treatment interaction is 0.009. And A1C was borderline, but we're hoping, because A1C is slower as a 3-month integrated measure, that we would see long-term effects. And we're doing the long-term follow-up for this right now. I think we're almost done. So, okay, so the past and current, we started in the West Bank. We previously have a Kentucky trial, Kenya program, India program, Jordan past cohort study, which you saw at the beginning, Jordan trial, and we're starting another one in Qatar. And so just a preview of the Kentucky trial. The Kentucky trial, we had this is in pounds because this is Kentucky. Intervention versus control. The intervention was the blue. The social network program was very effective in short term as well as long term. The 67 is it's basically 9-month program plus 16-month follow-up. And you can still see the intervention was sustained. Same for waist circumference. Long term was sustained. So overall implications. The Microclinic International Social Network intervention model holds promise of socially engineering and designing interventions around social networks to propagate healthy lifestyle in future public health programs. So thank you so much for your attention, and I really appreciate your time given this last talk. Thank you very much.
I can't help but comment about the fact that your study is also, I'm not quite sure, the Kentucky connection is very interesting to me because of my own personal relationship and background in that, so I'd like to comment about that in a minute. Are there any questions from anyone? We have time for questions, and come to the mic so we can all hear you.
Can I go? This is for Dr. Sandberg. I want to know, what role does socialization play in health-seeking behaviors? And then thinking about socialization, if you had to target an individual within the collectivist culture in order to promote that health-seeking behavior, who would you target? And then for Ameeta, I just wanted to confirm, are you saying that an insecure attachment contributes to synergistic effects of environmental exposures?
Okay, yeah, socialization, I think that the presentation focused on socialization being the key aspect to determining health-seeking behaviors. I think a lot of times we leave that out, and I think that's to our detriment in public health, right? That's potentially, I mean, we saw at the introductory plenary that, lots of interventions just go nowhere, and I think that's because we don't pay enough attention to socialization within prevailing cultural models. Now, who would I target? This is part of a larger NIH-funded social network project, right? And I'm really interested in measuring social networks. I don't think, I mean, within the network literature, of course, you can look at more central people. There are different metrics of network connectedness, and if you can find somebody who's more or less influential, that might be one thing. But we really haven't considered. The last talk we saw, they structured people and brought a social support group together, right? but finding an in situ, right, way to propagate that. I mean, certainly down the line, after we get this broader network data back, we'll be thinking about ways to introduce interventions and potentially trials to target, fewer people to get more results.
Hi. Is this working? Okay. Thanks for your question. Actually, in my study, we didn't assess attachment. We just looked at the profile of caregiver-infant interactions, which have been associated with attachment security in other studies. So I guess it's an exploratory study, like I mentioned, and it's just some early evidence because these infants were 1 year old when the developmental outcomes were assessed, and it's just pointing at a factor that's well recognized as a modifiable environmental factor that we may want to consider in this population because, pesticide reduction and risk reduction strategies may take a long time in order to have its effects. So this is something that could, combined with other, I guess the implications would be that combined with other interventions directed at other aspects of social determinants of health, this may be a factor worth looking at. Again, we plan to follow these infants up over time and look at the associations as they grow older.
Good morning. Josh Rosenthal from the Fogarty International Center. I have a question that actually sort of combines both the social network microclinic talk and the cook stove discussions that Dr. Thompson presented, and that is, you didn't describe, or maybe you went so fast I missed it, the size and structure of the micro networks, but they look like around 4 people or something. But if you could provide a little bit more detail of that, and then to what extent might that be applicable to probably one of the central problems in household air pollution and cook stove interventions relating to adoption and behavior change of those practices, and how much perhaps Dr. Thompson has thought about that approach in the context of Guatemala?
Yeah, thank you. Good question about the size of the social networks. It did vary in, we skipped over because of the lack of time, but in different populations, it's sometimes ranging from 2 to 3 to 4 to as much as 6. So on average, it was 3 to 4 individuals per social network group. But what's interesting is, and we didn't have time to go into it, so there's multiple family and friends social network cluster within each class. But within each classroom, the program was one classroom a week. So there's like 3 or 4 to 10, depending on the class size, of social networks in the same class. And in the multi-level effects, when we do the community, cohort, classroom, social network group, it was inherently the social network group that had the high intra-class correlation of the correlated trajectories in weight loss and A1C and waist circumference. You almost saw nothing of between individuals and social networks, between different social network circles in the same classroom. So it's all driven by social network, and the size varied. So I can't give you quite a number, and the Kentucky size is different from the Jordan. And what's interesting, Jordan oftentimes have many friends and family that has correlated genetics as well. So there's other complexities to it.
Thank you. Yes, that's a good question, and there are two aspects that I didn't mention that I could use to explain the idea of social networks. One is we're about to start a project in June looking at the distribution of LPG gas stoves using women entrepreneurs who will be trained to distribute the stoves, the LPG tanks, and provide household air pollution messages to the families, because we know they'll still be using other stoves in addition to an LPG stove. So it's really building the social network of the distributors who will get the messages out at the household level. So that's kind of a distribution issue. The second one is we just did a behavior change study with the people in the area where I work in Guatemala, where we brought in family members who make important decisions about modifying houses. So we could give somebody a clean stove, and the cook, who's usually the young woman in the house, would be happy to receive it. But if the mother-in-law or the husband or the other family members don't want to adopt that stove, it's not going to happen. So we actually have done some behavior change sessions with the entire family in groups of, the 10 women and their family member who makes important decisions to work together as a group to figure out how to avoid household air pollution, whether it's an individual behavior or whether it's a household behavior that requires some kind of modification of a structure. So we are looking a little bit more at that, but we haven't formalized it. It's really exploratory at this point.
Kiros Prohane from University of Southern California. My question is for Dr. Thompson. I noticed in the last slide you're thinking of scaling up to 200 pregnant women. So I have two-part questions. The first one is, what do you think will be the challenge for, in scaling up from 32 to 200 in terms of the study design, because some of your measures are actually quite intensive. And the second part of the question is even 200 enough? Speaking as a statistician, so what would be the challenge in actually having even larger studies? How much do you have scaled down?
Yeah, well, the limitation of our scale up that we actually have enrolled, I think, almost to 200, and it's part of it's a secondary outcome of another study looking at influenza vaccine among pregnant women and in Guatemala. So one of the challenges, of course, is money, because we're doing household visits using air pollution monitoring equipment. So we've scaled down the level of measurement. So my small study was able to do urinary metabolites and pH measures, which we can't do in that study. We're looking basically at continuous PM and CO. And yeah, there's a lot of problems with women who deliver at home. Therefore, we've selected women that will deliver at hospitals. And then infant neurodevelopmental assessment. Big Claws was not able to do it with that study at all those measures. So I'm hoping to be able to look at it in the future, but it's a significant problem because it is very labor intensive to assess infants at that scale. And statistically, I think that depending on what you're going to be looking at, like low birth weight, you're probably going to need about 700 people to see an effect in birth weight. So it's always a trade-off between large sample sizes and the cost of doing really good personal measures to air pollution. So I don't think 200 is adequate, but it at least will give us an estimate, some kind of exposure response, hopefully, but we're not really doing like a stove intervention trial there.
My name is Mashala. I'm coming from Botswana. My question is directed to the first presenter on the health-seeking behavior. It's quite a very enlightening, presentation in the sense that your analysis of the different factors and the interactions actually was quite good. Now, let me start by asking you the question, and then I'll just try to explain why I'm asking this. In your own opinion, health-seeking behavior is something that many people, in the health sector have worked on, trying to encourage, communities to seek health. Now, where are we? Are we at the lowest level, middle, or somehow this is unfinished business, and how much effort is still needed in order to achieve the desired goals? Why I'm asking this is because in one of your slides, you did allude to the fact that, biomedicine is not understood, which may be correct, but considering the level of knowledge in many societies, globally these days, and maybe the word understood is inappropriate. And I'm saying it's inappropriate in the sense that I'm trying to link health-seeking behavior to maybe godly-seeking behavior. Because there are people who are staunch Catholics. They go to church. The 1 hour that they spend in church on Sunday, they'll always be looking at the watch. And after that, they'll spend 4, 5, 6 hours, even 8 hours, in another church which is non-Catholic. But they are very well educated. They know what they are looking for. Now, I thought that maybe this is the kind of trend that we are seeing, in the, in the health, care practices. Maybe it is the weaknesses of the practitioners actually which are leading to some of our communities really not to seek, or maybe not to trust, or not to believe in what we do. So I would like to hear your opinion on that. And on the air pollution, maybe I missed a point, but why do it now? Is it that really the problem is, or the extent of the magnitude is so large? Are there studies which have been carried on maybe previously, looking, because I'm trying to link, the air pollution, particularly in confined environment, to maybe lung growth in school children and their performance. Thank you.
Okay, well, I'll see if I understood the question, and I'll try and get to it. I think, as far as not comprehending the biomedical treatment, I think that's part of the story, in the sense that this broader cultural model makes comprehending, right, the causal agents behind ethnomedically perceived diseases easier. But, if you walk out of this room into Washington, you ask people why they have colds, many people, I'd like to see a survey at some point, will tell you it's because they were outside in the cold, right? And we know that's not why. So people don't necessarily understand the biomedical model anywhere, but there are different attachments to it based on broader attachments to other schemas in these cultural models. Now, going to your other question, I think, if I understood it correctly, right, you're asking whether it's the weakness of the practitioners, right, the ability of the practitioners to provide healing services that is one of the weaknesses. And I think that's definitely true. I mean, on both sides. I mean, the feedback mechanism from experiences of efficacy is key to how people think about these things. And I probably went over it too quickly and didn't give like one of the key points to the presentation, so I'm glad you brought it up. When you read these disease narratives, you see iterative explanations of causation. People will start out with one thing, they'll start out with one type of health-seeking behavior, and based on their experiences in that realm, they'll shift their attribution and their causation, right? They'll move around. So the cultural model is really malleable to a certain extent, depending on how much it's associated with other aspects of it, with regard to health-seeking behavior, right, in people's minds. And they'll end up in one place, right? But they may have started in a completely different place. So it really all depends on perceived efficacy, which I think is what you were getting at.
Well, in terms of household air pollution, I think that there's two directions that we could move in. One of them is there are 4 million people dying annually from household air pollution, so let's just do something about it. And so those are the stove interventionists, the people that are putting stoves into households on national scale, the Global Alliance on Clean Cook Stoves, which is looking at scaling up among small stove producers. But unfortunately, a lot of the stoves that actually get out there into the communities don't do any better or minimally better than what's already there. And so on the other side are the researchers who are trying to really figure out what is the actual effect of this stove on hard to measure things like growth in children, cognitive development. In fact, cognitive development has not actually, there's a few studies right now doing this, but I think only 1 or 2 have actually published on it. So there we don't know what the relationship is between air pollution and cognitive growth, and there's so many other things, like I showed, where stunting is an impact. So it's multifactorial and it's hard to tease out the relationships. But so I think in the current research on household air pollution, it's let's do something about it because we know it's a massive problem. And then the researchers are saying, well, maybe we should really get the cause-effect relationship between the two. So a combination of both, I think, is needed.
So first, I want to thank all 5 presenters for very interesting and exciting work. And I really appreciated your talks. I learned a lot. One of the challenges of doing research in low-resource settings with vulnerable populations is balancing what we want to know versus what the populations actually need. So, Dr. Thompson, you've built this wonderful system to access what's obviously a very underserved population, just looking at the data that you show on the kids' outcomes. I'm just curious, multivitamins, tetanus vaccines, micronutrients, and I know we all have troubles with cost, but there are a lot of very low-cost things that we know work. Did you do any of these?
Well, I'm a nurse practitioner, so I always am looking at other things and getting involved in, it's multifactorial and it's very difficult. We worked with the Ministry of Health, so all of our recruitment and any child that we found that needed anything was referred to the health center. But yes, I think there's so many needs in terms of multivitamins, access to health care, what people actually want versus what we're doing. But we're in an area that's we've been doing this research for the past decade or so, and so we have people looking at food insecurity issues, and I just presented on one portion of it.
If I may add, so resource-limited settings, we usually think of low and middle income countries, but the Kentucky trial that we did was done in a very, very rural, impoverished county in Kentucky, Bell County, which is in southeastern corner, and their per capita income per year is just over 10,000, and per family household income is 19,000. So, and when the program was rolled out, obviously it was an obesity intervention program, but there was such a dearth of health education whatsoever in that county that the rolling out the program, such a large comprehensive program in all the communities in the county, actually catalyzed lots of other changes and positive health outcomes. So, I think it also cascades many other opportunities as well.
I just have one question for Stephanie, and I'm just wondering, this is a very interesting result that you're getting from this kind of what we would assume would be not the expectations that we would expect from having universal health care. Has that really reflected back or has had any discussion or impact with local or national governments as far as the implications for how this is being implemented?
So to clarify your question, you mean in Thailand, has there been responses to this? Yes, I would say there has been. Actually, it's something that I didn't cover in the talk today, but since 2010, when we did the survey, there actually have been additional reforms to the policy that allow for non-citizens, particularly migrants, to access services for 30 baht. 30 baht is the cost for services each year under this new plan, which is about $1. And so there have been reforms that have made, I think, a bigger impact for certain minority groups and underserved groups, but I still think that overall the way that the plan is implemented is quite bulky or restrictive in the way that these catchment areas or primary care units are set up. So I think that there could be additional ways to make the plan more flexible so that individuals are able to choose where they can go for care. And I think there are also, I didn't talk about ways that we could improve care for these particular groups, but I think there are ways to invest more in the community health worker services that are already there. That was one of the first primary care interventions in this area. And I think that there are ways to invest in local existing village health volunteers in order to train them both in home-based care and also in taking people to the hospital when that's an important need, and also providing interpreter services when that's needed as well. And I think with the village health volunteers that I worked with in Thailand, they are very motivated to help more, but because they're not paid very much at all, if anything, there's a huge brain drain in the villages and also just a large turnover rate, and it creates a lot of burden. So I think there are ways to invest in an existing really effective program that's just underutilized and not as effective as it could be, really.
Well, thanks to our panelists for excellent presentations and very provocative discussions from the audience and their questions. And that, I think, concludes our session. Thanks very much.